probably on Monday, so we'll do the hepatic and hemolymphatic. And like I said yesterday, there's not enough time to do everything in depth. What you have in your notes is more than you're going to be held responsible for as far as exams are concerned. So on your exam on Tuesday, you'll just get what we cover in class. And it'll probably be multiple choice. I found some multiple choice questions last night, so hopefully you'll be able to answer most of them. Answer all of them. So I'll go over some of the questions on Monday, and you'll be ready for the test on Tuesday. All right. So cardiovascular disease in cattle. So this is a nice article coming from British Magazine in Practice, and it just summarizes some of what we've already spoken about. They talk about incidence of cardiovascular disease in cattle being quite low. Part of the non-athletic, I love that term, non-athletic. Everybody see this and paying attention?
I can't hear you.
Okay. Got it. All right. Pay attention. I was kind of in a philosophical mood last night. I guess when you have children, you have to be. And, one thing I keep telling them is that you need to grasp opportunities now. When you're young, you feel like you have, 100 years ahead of you. Right now, I probably have, hopefully, about 50 years ahead of me. But, so what I always emphasize to children and my students is to grasp these opportunities now, right? You already have the slides and the notes, so the tendency is to sit back and, arms folded and, appear to be bored until I'm finished. But if you really listen to what I'm trying to impart to you and make note and pay attention, it'll pay off in the long run, all right? As I said, people are crazy.
That's a computer problem.
It's not a me problem.
No.
It's not me. All right, so cardiovascular disease in cattle. So this article comes from In Practice magazine, and it talks about the incidence of cardiovascular disease in cattle being low. They're non-athletic, and so it's usually not detected until they're severe or compromised. So that's one reason why yesterday, for example, I said that out of the in-depth diagnostic equipment, we don't necessarily have to use it in ruminants, because by the time they present with cardiovascular disease, it's going to be pretty well advanced. All right. Today we're going to talk about ventricular septal defects and patent ductus arteriosus. They're quite rare, but those two are going to be the more frequently encountered congenital defects in cattle. And DSD is probably number one, so we'll talk about that in a minute. All right. Also, diseases of other systems, for example, the respiratory system, may produce clinical signs resembling those of cardiovascular disease. So we spoke about that yesterday, about everything being interconnected. So when you're presented with a disease that's apparently in one system, you have to continue to examine the entire animal to see if there's any other system involved. All right. If you've been out in the pasture with me, you'll notice that the heart is located almost entirely behind the triceps muscle. So again, you have to make sure you're pushing the stethoscope behind the triceps and really making an effort to listen to that heart. Let's see. I hope you can see this on the screen. We spoke about the heart sound yesterday, S1, S2. Theoretically, there's an S4 and S3. Practically, you're just going to hear S1 and S2 in the vast majority of cases. You're just going to get two heart sounds in the majority of cases. As far as grading the intensity of murmurs, you guys already did that in some of your other classes, right? You did that in what? Small animal cardiovascular? Hmm?
Yeah, most of the time it's the one group.
Yeah. So, grade 1, 2, 6. So I'm not going to test you on that since everybody hasn't done it. But, it's self-explanatory. Grade 1, nobody can hear. Grade 6, everybody can hear. And it's between grade 1 and grade 6 as far as variations in intensity. All right. As far as the ECG or EKG, so unlike some species like humans and small animal, where you can infer based on the size of the QRS complex, for example, you can infer the size of the heart and whether there's left-sided or right-sided enlargement just from the shape of the QRS complex when you're doing ECG or EKG. In ruminants, and due to the extensive Purkinje network, the Purkinje fibers that are conducting the electrical impulses through the heart. So due to it being so extensive, you can't really infer anything about the changes in shape of the heart. So you can't infer that there's left-sided or right-sided heart failure just by looking at the QRS complex. So basically, in cattle or in ruminants, you only use the ECG to determine the rate and the rhythm. All right? So that's another take-home message there. We spoke yesterday about the basic XV, standard unit recording, and ECG. And yesterday you saw a P wave and a large, mainly negative QRS complex, and a positive or isolated T wave. So this is showing that again. You saw this yesterday. So you have your P, QRST, and when I say negative, so that's the baseline. So you see that the QRS complexes are predominantly negative. So P, QRST, P, QRST, and keeping like that. So this is a nice regular heartbeat. You see the distances between your QRS complexes are pretty steady. All right. So that's just a review of what we did yesterday. So what we're going to do today, we're just going to look at a handful of conditions, and they're going to be on the good old-fashioned overheads. I like overheads. And I can't fit all this onto a slide. And it helps me to put them side by side so you can compare and contrast. So we're comparing and contrasting. So grouped under the heading of developmental or congenital diseases. So you have ventricular septal defects, patent ductus arteriosus, and tetralogy of Fallot. All right. So those are the three that you're going to be held responsible for: ventricular septal disease, ventricular septal defect, patent ductus arteriosus, and tetralogy of Fallot. So tetralogy, so tetra means 4. So 4 defects making up tetralogy of Fallot. All right, so a couple of things that you'll notice when you look at them side by side, and you can either do this yourself or you can just read the notes that have already been provided to you. Don't email me and ask me to send this to you. I'm presenting it now. Remember, I just spoke 5 minutes ago about grasping your opportunities now. If you want to take a picture of it, you can. So just pay attention. So ventricular septal defect, most common congenital cardiac defect in large animal. And you guys know by now, you're in your 3rd year, so you know by now anytime we present something to you as most common or least common, we have to test it, right? We just have to give you a test question about that. All right, so the ventricular septal defects are the most common congenital cardiac defect in large animals. All right? And where they occur? They occur in the ventricular septum, mainly high up in the membranous septum. You maybe have that muscular septum, and then the membranous septum takes over. So mainly high up in the membranous septum that divides your left and right ventricle. Usually it's just going to be one defect, or usually it's just going to be the ventricular septal defect that's present, or it can also be part of another anomaly. So what that tells you is that if you detect a ventricular septal defect, you're going to look to see if there's other defects present, maybe a PDA or maybe even a tetralogy of Fallot. And another take-home is that it may be hereditary. So ventricular septal defects may be hereditary in the limousine breed and possibly in the Hereford breed. We don't have any limousine, but we do have Herefords out there in the pasture. Those are the guys with the red body and the white head, white face. So possibly hereditary in Hereford, okay? So we know we'll probably test you on that also. So comparing ventricular septal defects to PDA, patent ductus arteriosus. So you guys remember from one of your classes, anatomy, I guess. Did you go into a little embryology in your anatomy class? Yeah. So you remember the ductus arteriosus. So when the fetus is in utero, it uses the ductus arteriosus to oxygenate its blood. And then when it's born, usually the ductus arteriosus separates. So occasionally, or closes. So occasionally you have an animal that still has a patent ductus arteriosus. So that's connecting the pulmonary artery to the aorta. So you can see what would happen if you have that connection still patent. So a lot of your oxygenated blood is not getting so the lungs are not oxygenating some of your blood that's going through the aorta to the rest of your body. So your body's going to be deficient in oxygenated blood, basically. One important thing to recognize about the PDA, so when you're auscultating foals, it can be actually normal for the ductus arteriosus to be patent up to about four days of age. So you're auscultating a newborn foal, and you might hear that machinery murmur, and that's normal. It takes a couple of days for their PDA for their ductus arteriosus to close, whereas in ruminants it should be closed at birth. So it would be not normal for you to auscultate a newborn calf and hear a machinery murmur, to hear that patent ductus arteriosus. So that's important for you to know. Again, test question. So, 4 days. Yeah, it should close, within 4 days in horses, whereas in it's open it can be open at birth in horses, and it should close by 4 days. So you can have a patent ductus arteriosus in foals up to 4 days of age, whereas in ruminants, they should be born with their ductus arteriosus already closed. All right? And that's another test question that's commonly asked, either here or on the NAVLE. PDAs are also usually part of a complex anomaly. So again, if you detect a PDA or a ventricular septal defect, you should start hunting for some other anomalies as well, some other cardiac anomalies. And for PDAs, we're not certain if it's hereditary or not. All right. Tetralogy of Fallot, you'll just have to memorize what constitutes the 4 abnormalities that make up the tetralogy of Fallot. Tetra means 4, so tetralogy of Fallot. So you're looking for 4 abnormalities. So overriding aorta, so that just means that the aorta, instead of coming off of, which ventricle does it come off of? So instead of, I guess someone saying left, so comes off of left ventricle, right? Right?
Yes.
Okay. So instead of coming off one ventricle, when they say overriding, that means that it's coming off of both ventricles. So you can imagine the problems that that's going to create as far as mixing of oxygenated and deoxygenated blood. It also has a ventricular septal defect involved. There's also pulmonic stenosis involved. And then a sequela of the pulmonic stenosis is going to be the development of right ventricular hypertrophy. So 4 constituents of tetralogy of Fallot. I don't like to memorize, but this is just one thing that you're going to have to memorize, those 4 constituents that make up a tetralogy of Fallot. Occasionally there's a pentalogy of Fallot where there's an atrial septal defect as well as a ventricular septal defect. Tetralogy of Fallot happens to be more commonly seen in calves and foals, and it's unknown if hereditary. Let's see, you guys are just getting in 3rd year. So were you aware of that cat that was here last year, Twitch? Yeah, so that cat belonged to a friend of mine from the good old days in Jamaica. And I drove down to Florida to get Twitch and brought him up here. She said it had a tetralogy of Fallot. And she's a doctor, so of course she's right? So we corresponded, and she said, yes, it has a tetralogy of Fallot. I said, really? In a cat? It's pretty rare. She said, yes. And she had it worked up, and et cetera, et cetera, et cetera. And it came here, and is anybody aware of what the final diagnosis was on Twitch? Yeah, I don't think it turned out to have all 4 of these. I think it was just a ventricular septal defect, at least according to us. We're veterinarians, but I kind of joke back and forth with my friends. So she's a doctor. She knows what she's talking about. Anyway, the pathophysiology of ventricular septal defects versus PDA versus tetralogy of Fallot. So I just outlined that here because I'm not going to test you on pathophysiology, but just for your own interest, it's interesting to see what the consequences of having these defects are going to be. So you can imagine with a ventricular septal defect, for example, you're having this shunting of blood between the ventricles, and that leads to a volume overload of your right ventricle. So eventually you're going to get right ventricular heart failure, that's true. So eventually you get developmental congestive heart failure, but you're also getting failure of both the right and the left ventricle. And in addition to failure, so you're getting hypertrophy until they can't get any bigger. They can't continue to work as hard, so they eventually fail. But you're also getting this this shunting of blood leading to excessive turbulence. Remember we spoke yesterday about the laminar flow, and either there's something in the blood, so something like anemia, or something within the heart, within the vessel that the blood is contained in, some change that causes turbulence, that causes a deviation from that smooth laminar flow. So in the case of the ventricular septal defect, the shunting of blood between the ventricles is what's causing this excessive turbulence, and you can imagine excessive turbulence within the heart is going to cause damage to the inner lining of the heart, the endocardial lining of the heart, and it can lead to endocarditis. So these are some of the sequelae that result from ventricular septal defects. And with the patent ductus arteriosus, you're also getting shunting, but this time between the aorta and the pulmonary artery. And again, you're getting overload of the right ventricle, similar to what you get with the ventricular septal defect. So once again, you're getting pulmonary hypertension, leading to congestive heart failure. So with both the ventricular septal defect and the PDA, the ultimate result is usually congestive heart failure. All right. With the tetralogy of Fallot, the big problem with tetralogy of Fallot is that you have so many defects that are causing so much overload and so much mixing of oxygenated and deoxygenated blood that the hallmark of tetralogy of Fallot is going to be the severe cyanosis. Okay, so Twitch didn't have severe cyanosis. Occasionally people look. I'm talking about the cat now. Occasionally people look kind of pale, but severe cyanosis is going to be one of the hallmarks on presentation. So if you're reading a case and they're describing this weak little calf or weak foal, and it presents you with severe cyanosis, hopefully somewhere a light will go off, and you'll say, I wonder if that's a congenital cardiac defect, maybe even a tetralogy of Fallot. All right. So with all this shunting of blood back and forth and, mixture of oxygenated and deoxygenated blood, you're getting certain typical clinical signs. So with ventricular septal defects, the hallmark, which you'll read, whether you're on the NAVLE or in this class, the hallmark description that you'll hear is they'll talk about a pansystolic murmur on both sides of the thorax. So on the left side and on the right side, you're hearing this murmur that's present throughout systole, and a palpable cardiac thrill. Okay, so you're going to see this phrase repeated, these two phrases repeated whenever they're talking about a ventricular septal defect. They're going to talk about a pansystolic murmur and a palpable cardiac thrill. Palpable cardiac thrill means that you're just resting your hand lightly on the chest and you can feel this vibrating sensation. All right, so these are two of the clinical hallmarks of ventricular septal defects. Pansystolic murmur, so you're auscultating it and you're hearing this murmur that occurs all throughout systole, and when you rest your hand on the chest, you feel this vibration, palpable cardiac thrill. All right. The hallmark of the patent ductus arteriosus, and you'll see some variation of this phrase every time you're dealing with a PDA, is they'll talk about a continuous murmur, they'll talk about a high-pitched continuous murmur, they'll talk about a washing machine type murmur if they absolutely want to give it to you. I probably won't give it to you and tell you it's a washing machine murmur, but certainly it's a continuous high-pitched alternating murmur. Okay, and continuous means just that